So I think we're ready to go. We have a number of people here. We have a larger number online today.
Okay.
I'll start with a brief introduction and we can get started.
Okay.
All right, so it's my pleasure today to introduce Olayinka Shiyanbola. Dr. Shiyanbola is an associate professor in the Division of Social and Administrative Sciences at the University of Wisconsin-Madison School of Pharmacy and an associate director for the Collaborative Center for Health Equity. Her research program advances the use of patient-centered interdisciplinary approaches to improve diabetes and related chronic disease outcomes in underserved populations, medication adherence, health literacy, and health equity. Currently, her research is focused on designing and implementing behavioral interventions that incorporate psychosocial and social cultural factors in improving medication adherence, diabetes self-management, and health literacy. Dr. Shiyanbola was a NIMHD Research Institute Scholar, an NHLBI OBSSR Randomized Behavioral Clinical Trials Fellow, and an NIH Mixed Methods Research Trainer Program Scholar, as well as a Societal of Behavioral Medicine Leadership Fellow. She is an appointed member of the National Academies of Science, Engineering, and Medicine Roundtable on Health Literacy. Her work has received numerous awards and recognitions at national and international scientific conferences, including invited talks, symposiums, and seminars. It's my pleasure to introduce Dr. Olayinka Shiyanbola.
Well, thank you so much for that introduction, Dan. I really appreciate it. And thank you so much to the Center for the opportunity to present today and talk a little bit about some of the work that I've been doing. Like I said at the beginning, I wish I could be there in person, but looking forward to July to being there at the Midwest meeting. So today I'm going to be talking about using mixed methods in pharmacy health services research and how that has informed research tools and interventions. So I want to start off a little bit with some very simple definitions of what exactly mixed methods is. I like this definition by Johnson et al. In 2007. It's a very simple definition that identifies the purpose of a mixed methods research study. I like it because it talks about the fact that researchers or a team of researchers, which is what you find in a lot of mixed methods research design teams, is coming together of different individuals who have qualitative and quantitative research viewpoints and combining that to answer a study research question. The purpose of a mixed methods study, of course, is to increase more depth, more breadth, more understanding, and also to be able to corroborate the study findings that you're getting from the different viewpoints. This definition, however, has a little bit of controversy to it because a lot of mixed methods researchers say, well, as long as I combine the elements of data collection approaches in one study, well, that makes it a mixed method study. And so my goal today is to help you understand that there is a more rigorous way to thinking about mixed methods besides combining them together in one study and then calling it a mixed method study. So I want to introduce to you a really good definition that I use and I really like, which is the NIH definition. It's vetted by NIH, it's vetted by a lot of mixed methods, NIH researchers. And I like it because it breaks down into more specific details on what mixed methods research is. And this is a very good example of these details, which is it focuses on research questions that helps you think about context. It's thinking about different levels of perspectives. I also like the focus on rigorousness. So NIH definition thinks about both the quantitative research and the qualitative research has to be rigorous on its own independently before you combine them together. So what that means is if you are doing quantitative research and you're looking for association of variables and looking for magnitudes and frequencies, just like you are thinking of credibility and thinking of the validity of your quantitative study, you also have to be thinking about the rigorousness of your qualitative research. And then bringing rigorousness into mixed methods research is paramount and critical. This definition as well thinks about the fact that mixed methods uses different multiple methods, and this is where the idea of pragmatism comes in, and you see a lot of mixed methods researchers talk about that pragmatism is focused on the fact that what is critical and important is answering the research question, and you should be free to use any type of method in answering the research questions. This definition as well thinks about intentional integration, and you're going to see me talk a lot about that throughout this presentation. And what that means is that your qualitative addition or your quantitative addition shouldn't feel like an afterthought. It should be integrated right from the very beginning, from the planning of the study to the design of the study, right from the very beginning. And basically, you are combining to draw on the strength and offsetting the limitations of either type of methods. And there's this definition as well, thinks about you need to frame your investigation within philosophical foundations. So for example, in qualitative studies, you think about constructivist, which is where you as a researcher, you're thinking about the perspectives of the participants, whether through interviews or observation, and you're co-constructing your meaning of your phenomena, basically, together with that of the perspectives of the interviewee. However, when you think about quantitative, it's more empirical. In mixed methods, they call it a very post-positivist theoretical foundation, and you're bringing both together to then think about pragmatism, which is what mixed methods design thinks about. So mixed methods have several advantages, and I'll try to give you, of course, what are some of these advantages, but also talk about some challenges. Mixed methods research allows you to be able to get more insight. It enhances the totality of the evidence that you're getting when you're studying your research problem. So you're gaining new knowledge. And actually, there is this analogy where in mixed methods, is 1 + 1 is equal to 3, not 1 + 1 is equal to 2. And what that means is that when you are conducting your mixed methods analysis, it is a third type of analysis, which gives you more insight beyond just combining it separately. And so you're gaining new knowledge. The nice thing about this design as well is that there's always the adversarial divide that we see. Oh, I am a very quant researcher, or I'm a very qual researcher. And mixed methods brings us all to the middle. It's a bridge. Now, the idea of pragmatism comes in, which is that it's very practical. You can use any type of methods because you're focusing on identifying and understanding the research problem. There is this benefit as well of scholarly inputs to think about as well, which is you are able to produce multiple written publications. I know it sounds like a very selfish reason, but a very important one. In a mixed methods research design, you can publish quant articles separately from a qualitative article, and we've done that in some of our work. Something that we've also done is combining both the qualitative and the quantitative together in one study. Another thing you could do is produce another publication, which is a methodological article, where you are writing about how your study has actually advanced the understanding of mixed methods research. And we see a lot of mixed methods research journals like GMMR, the Journal of Mixed Methods Research, who most of the time they are looking for additional articles that is thinking about, by doing this study, how have I advanced more knowledge about mixed methods research study designs in general? And the other thing is, as a researcher, you're also developing broader skill set. You are getting to know more. Like I said, that mixed methods level analysis, you are then able to combine it together, and you are developing more skills, which is very important, especially for grad students. Now, having said all the really great things about mixed methods, there are some challenges. I'm going to be very honest. As a researcher, you need to have the skills when it comes to data collection, whether it's qualitative, knowing how to analyze qualitative separately, also knowing how to collect the data separately, and also that's third level of analysis, which is knowing how to combine both the qualitative and quantitative to then understand the interpretation of your mixed methods data. It takes a lot of time. which is true. It's a lot of data to analyze, especially in sequential designs where you have to analyze the qualitative first, analyze that, and then wait to then conduct your quantitative and then merge them together. So it's a lot of data. It involves teams. And most of the times you're looking for people with different methodological expertise, but not necessarily. But one of the things I like about mixed methods is that there is this coordination of bringing people who come from a very different viewpoints together to look at the research question with a very different approach and a very different lens. One of the bigger challenges that we see with mixed methods is knowing how to combine them together and systematically at the beginning, and also integrating the two databases. However, hopefully today I'll be able to show you some examples on how our team has been able to do that and give you some idea. So I want to talk a little bit about what are some common reasons why we might use mixed methods in pharmacy health services research based on what is currently available in literature and what we've also seen in other studies. Now, this is not all encompassing of all the reasons to use mixed methods, but just to give you some examples. So first, you are looking for completeness and corroboration in your results. This is where the idea of complementarity comes in, because you are trying to offset the limitation of your qualitative research on its own, or trying to offset the limitation of your quantitative research independently. So you might think about, I want to conduct a mixed method study because the ability to generalize is lost with my qualitative, and the quantitative research doesn't give me context. It doesn't tell me about the nature of the associations that I am seeing in my big data. So you are looking for completeness of stories. You are trying to investigate your problem. You are trying to see if you can look at your research question and examine it from different angles. The nice thing about mixed methods is that the results sometimes are contradictory to each other, but you would never know that if you had not used mixed methods. And you would never have discovered that if you had only focused on one type of data. Another reason to use mixed methods is to explain your initial results, and we see this in a lot of explanatory sequential designs. And this is where we see with a lot of individuals who do secondary data or who just conduct a single mono-method approach of quantitative research, because then you don't really understand completely what is the meaning of the quantitative results you just found, because your quantitative results just gives you a description of the association between your variables. It doesn't really tell you what that statistical test really means. By adding a qualitative component, then it gives you more understanding and the nuances of what is actually going on between the variations that you're seeing in your samples. Another common reason is development. This is a very common one that we see, which is when you're trying to develop a new instrument, when you're trying to develop a new tool, or you're trying to adapt a new tool. This is used a lot when, as an investigator, sometimes you don't even know what questions to ask. You don't even know what variables you want to measure because the topic is so new, or maybe a specific marginalized population. No one has studied that topic in that population before. And you don't want to use the same instruments that are already available. You want to think about what else can I think of, what hours can I adapt these instruments to fit my specific population. And so mixed methods research allows you to do that. It allows you to also explore questions, and then you can then explore those questions with qualitative, and then be able to follow that up with some quantitative study to then look for generalizations. And then finally, a very common one that we see is enhancing and experimental studies using clinical trials, pilot feasibility, acceptability studies, and adding the qualitative methods, also a very common one that we see. Because in quantitative, your intervention is only looking for the possible effectiveness of your treatment or intervention. and looking for effect sizes and looking for those statistical significance. And adding a qualitative research gives you an understanding of an aspect of the intervention. So for example, by including qualitative research, it allows you to know, why did people not show up to our intervention? Why was there a lot of attrition in our intervention? Was the intervention even acceptable to our participants? However, a lot of people use qualitative research and embed it into experimental studies, mostly at the end. Something that we're also beginning to see and actually is being used now is even prior to the beginning of the intervention, conducting a qualitative, including qualitative methods. So for example, what is the best way to deliver the intervention? Starting with a qualitative component prior to the intervention allows you to know that, how can I recruit? How am I going to organize and present information to my participants in my intervention? How am I going to retain them? Doing all of that prior to the experimental study in a mixed methods design is a way to also enhance your clinical trial or enhance your intervention. So those are the common ones, like I said, that you see in pharmacy and you see in a lot of literature. So now I want to turn our attention to the common types of mixed methods designs that are out there. Now, this is the typology that is used by John Presswell and a lot of individuals who started this idea of mixed methods a long time ago. And its typology is based on the very 4 basic designs. The convergent to concurrence design, which is when you're bringing both qualitative and quantitative together at the same time. You have the explanatory sequential design, which is where you start off with a quantitative study and then sequentially you go on to a qualitative. We have the exploratory sequential, where you start off with a qualitative design and then sequentially move on to a quantitative, and then the intervention design, which I talked about. Now, these are the 4 most common types. There are other more advanced types of designs that we'll see. There is the case study design, there is the participatory social justice design, and also the multi-stage design that are also used, but I just wanted to, for today, focus on the most common ones. So I wanted to give you an overview of integration in mixed methods. And this is a study that I actually published just last year with one of my graduate students. And the idea of this figure is to show you what makes a rigorous mixed methods design different than a multi-method. A multi-method design is basically saying, I collected qualitative, I collected quantitative in the same study. Did you bring them together in some type of way? If you didn't, then it's not exactly a rigorous mixed methods design. So what we've proposed, and if you want to read more, you're also welcome to look at this paper, is that starting from the planning of the study, you need to start thinking about how you're going to integrate both your qualitative and quantitative. Right integration happens at the design stage, which is the blue. Then integration also needs to happen at the meta stage, and finally at the reporting stage. And I'll walk you through a little bit of what I'm talking about. So you've identified your research gap, you've identified your research objectives. That is what drives the choosing of your mixed methods design. And the integration at the design stage is basically choosing what type and choosing the typology. Now, for the concurrent, for example, when you move on to the meta stage, we have what we call the connecting. What that means is that you are sampling both the individuals for your qualitative study and quantitative study at the same time before the data analysis has even happened. An example of this is a study that we did where we did focus groups with some older adults. And while we did the focus groups, we also collected surveys at the same time that they were in the room with us. Now, how do you integrate at the analysis stage? You're basically merging and you're looking for that complementarity that I talked about. And you're beginning to look for the comparisons between your quantitative and qualitative finding. Now, that is very different from the other blue, which is the explanatory sequential. The explanatory sequential is when you start off with a quantitative study, after you have analyzed your quantitative study data, based on the results, it's when you then do your qualitative sampling. And that is what I mean by qualitative sampling based on your quantitative results. Now, the quantitative needs to happen first, then sequentially you move on to the qualitative. Something that we also see is in building, you can build the results of, you can build your interview guides, and we've done that in some of our work based on your quantitative results. Now, when you get to your analysis stage, what you are looking for are, now I have high or low, or I have different levels of health literacy. What are the variations between my separate quantitative samples that were differentiated based on my quantitative results? And I'll show some examples. Then explanatory sequential, like I said, is one of the most common ones we see. We are trying to develop a new instrument. We are trying to adapt a new instrument. And this is the building stage where your intervention may be developed based on your qualitative results, or your quantitative instruments is developed based on your qualitative results. And what you're merging is then trying to see if there's congruence between your qualitative and quantitative after you have looking for more generalizations. And then finally, you have the advanced design where you are embedding. And like I mentioned, when you're including the qualitative within your quantitative intervention or your clinical trial, it can happen before the intervention, during, and after. Now, doing it all at all stages seems like a lot. And so sometimes we see a lot of people who just do it only before the intervention starts, or only after, which is the most common, or even during. And then your merging is bringing all those results together. Now, that is the integration at the method stage. Then integration also needs to happen at the reporting stage. So you see that it needs to be a continuum of your integration right from the very beginning. Now, a method of reporting could be narrative, which is just writing about your integration in text form in your manuscript. And a very continuous approach is where you just write it all in one manuscript, and you write your quantitative in one section, and then you write the results of the qualitative in another section. It is a very simple way. However, something that we've also done is a weaved approach, where we write about the results theme by theme or concept by concept. So my concept, for example, is maybe medication adherence. That is my theme. And then I write the quantitative and qualitative results. And you continue to do that throughout the manuscript, writing about it concept by concept. And then a staged approach is basically you just publish them in separate articles. There is also the data transformation, which is used a lot for content analysis, going from qualitative to quantitative. And then a visual approach, which is your joint display that I will show you an example of how to also integrate your data. So something to consider when you're thinking about mixed methods is there fit and is there coherence between my quantitative and qualitative findings? There are three possible outcomes that you could get when you're thinking about the fit of your integration. There is confirmation, which basically means, well, I put my study together and I got similar conclusions. So basically, both types of data, I have confirmed the results, and it's basically increasing the credibility of your findings. There is also expansion. What this means, sometimes the qualitative and quantitative data, they diverge, but maybe the quantitative data is further expanding and giving you more insight on the phenomenon of interest. So maybe the quantitative data tells you about the strength of the associations, and your qualitative data tells you about the nature of those associations. Discordance, if you remember, I said sometimes the data are inconsistent, and we've seen that happen in our work where the qualitative and quantitative data do not make sense. They are contradicting each other. They are not speaking to each other. And there's nothing wrong with that. Something that we've seen a lot of people do when there's discordance is they try to explain it using theory, trying to use some theoretical explanations, trying to think about the validity of the constructs. Maybe some people even go back and collect more data, or say we would do future studies to help us explain why there's discordance. And so trying to rationalize why there is discordance in between your qualitative and quantitative data. So what I want to show you now are what are some of the ways that we in our work have communicated the integration of our data and integration of our mixed method study. Now, this is a study that we actually just published, thankfully, just last week. And we use in this study what we call a procedural diagram. A procedural diagram is basically a visual way to be able to communicate your mixed methods, study aims, your procedures, what your possible products could be. And you could do it it's a way to just visualize and communicate to maybe a grant reviewer, or we've even included it in our study protocol sometimes to let people know what exactly am I going to be doing in a mixed method study? Because a mixed method study can be very complex. There are multiple parts to it. And so this is a very nice way to show that using a very bird's eye view of all the things that are going to happen in a mixed methods design. So this was an explanatory sequential design that we did. We were looking for the feasibility of a randomized control mixed methods trial. We were including health literacy concepts and psychosocial concepts into a clinical pharmacist-led clinic over here in Madison. And we wanted to show what we were going to be doing. So for example, if you look at the left column, we started talking about what we were going to do as our pre-test procedures. This is a pilot study. These are adults with diabetes. We showed that we are going to randomize them into intervention or usual care group. Now, because this is an explanatory sequential, our quantitative aspect is the intervention trial, right? That is where we are looking for the effectiveness. Or we are looking for our feasibility, not effectiveness, or signal of changes in our outcomes. For this explanatory sequential design, we embedded our qualitative component during and after the intervention. So after the intervention, as you can see, after we did our post-test, yes, we're going to do regression analysis, we looked at acceptability after the individuals finished the intervention. So we did those one-on-one semi-structured interviews. However, during the intervention as well, we audio recorded the conversations that were happening between the pharmacist and the patient as another form of qualitative data collection, because it was important for our aims. And then, of course, at the end, we discussed our themes in the context of the intervention. So basically, this is a procedural diagram that just shows you in very simple detail what exactly our design was going to look like. It was nice because everyone on the team, they kind of knew what we were doing. We published about it, and we even included it in the grant that we in the grant that was actually going to be, that eventually funded the study. Now, another way, if you don't want to do a procedural diagram, is to do what we call an implementation matrix. Now, this is an implementation matrix of also another explanatory sequential study where we were looking at changes in medication adherence over time among Blacks with diabetes. And actually, this study is going to be, they're going to be talking, my students are going to be talking about it in a podium at APHA this weekend. Now, what makes an implementation matrix different from a procedural diagram is that it gives you more, while the procedural diagram gives you big picture, this gives you more detail. And as you see, we were able to show what our quantitative aim is, our qualitative and our mixed methods aims. We spend a lot of time also talking about all our data collection procedures. We are going to do complete sampling. We talk about our data analysis procedures, our outcomes, and we add a separate column where we talk about how we are going to integrate all the data together, which is the very last column on your screen. And we use theory to actually connect our qualitative and quantitative, and we use the integrated theory of behavior change. And so this gives you a very forest eye view of all the details. So this can be very overwhelming, but for us, it was important because different members of the study team were involved in various data collection and analysis, and it was important for them to see where all of us were all going to come together and merge. And so after the quantitative was done, we sampled individuals based on their change in their medication adherence score over time, and then we did our qualitative interviews. So if you see the qualitative section, we say we are going to do deductive and inductive content analysis. We are looking for themes and quotes. And then our mixed methods aims, while we talk about our procedure, is going to be matching our theory based on the scores from the quantitative and the qualitative and bringing them all together. So it's telling the reviewer or telling whoever sees this, this is sort of our intention for our mixed methods design. And then, of course, we do back and forth analysis for our procedures. For the mixed methods, we do meta inferences, and I'll show you some examples of what that looks like. And for this study, we use the joint display in reporting our findings. Now, you might not want to do a procedural diagram or implementation matrix because it is kind of a lot. And even though I've said we put it in our grants, we include it in our manuscripts, in our protocol papers, there is another very simple way of showing integration. And this is an example of one of my PhD students who actually graduated 2 years ago for his dissertation, did an exponential sequential mixed methods design. Very simple way. Was 3 phases for his dissertation. He did his quantitative data collection analysis. Based on the results, he selected the cases that of individuals he wanted to interview, did his qualitative, and then integrated. And this is what he included in his dissertation and even in the presentation of his dissertation proposal. Another way, if you don't want to do any of that, of showing that you are showing the purpose of your data integration could also be writing a mixed methods aim. And we've seen some people do it. And actually, my student published this in the work that I just included there, as I have a quantitative aim, which is I'm looking for the barriers and facilitators across people with different levels of health literacy and its association with medication adherence. And then it has a separate qualitative aim, which is I want to explore the perceptions of those barriers and facilitators. And then he wanted to show integration by writing a third aim, which he then called a mixed methods aim. And his mixed methods aim is basically saying, I want to understand how the data from my interviews is helping me explain the results on my surveys, because this was an exponential sequential design. So this is another approach of communicating the integration of your, of bringing both your qualitative and quantitative together. Now, we've talked about integration in design right from the very beginning. Another way of showing integration is, remember I said, is when you're actually reporting the results of your mixed meta study. And this is an example of one way to do it, which is what we call a joint display. A joint display was somebody that, it was coined by a very good dear friend, Tim Gutterman, who has written a lot of studies about how to bring data in a visual form, bringing your data results in a visual form using a joint display. Now, in this study that this my prior graduate student did, each joint display showed a summary of its quantitative data, a summary of its qualitative data based on concept by concept, which in this case, the concept was self-efficacy and how that impacted medication adherence. And then a separate column where he merged the results, and that is what you call the meta-inference or the explanation, which is what does it mean when you bring both together? So for example, if you look at this data summary, it says right up below, among participants who had low medication adherence, we found out that adequate health literacy was found in those with higher self-efficacy than those with inadequate health literacy. Well, that is what your quantitative data tells you. That's it. But then because he did an exponential sequential design, he was able to also say that, oh, among those who had inadequate health literacy, there was more occurrence of impediment in their confidence in medication adherence because of these perceived situational influences. And then when he merged the results together, he's able to say, well, low adherent patients, they stopped taking their medications, but it occurred more often during those with inadequate health literacy. So basically what I'm showing you is that this is one way of showing how your qualitative and quantitative data connect by just doing a joint display. Now, this is an example of another way that we've done a dunce display if you don't want to do a summary. Now, this is the study that I talked about where I said we're looking at medication adherence over time among Blacks with diabetes. After we looked at the changes over time, how many people increased their adherence over time, how many people decreased in their adherence over time, we then qualitatively sampled individuals between those distinct quantitative sample groups and then interviewed those people. And this is our way of reporting the integration. If you don't want to do a summary, you can just put the results. So in our joint display, we show that this is the results in their mean score change between the increased group and the decreased group. We showed what the qualitative themes are in the comparison between both groups, the quotes they talked about, and then finally our explanation, or if you want to say meta-inference, we then show that, well, our patients in the increased adherence groups, this is what they told us about when we interviewed them, and our patients in the decreased adherence group, this is what they told us. And we begin to see that there is differences qualitatively between both groups, which we would never have known if we didn't bring all the results together. So this is an example of another way of showing the integration of your data as well by putting the actual results instead of a summary into a table. Now, if you don't want to draw a joint display, because yes, they can be very hard to do sometimes we just write about it in narrative form. And actually, this is an excerpt from something from the paper that I said we just published last week. We just wrote about it in narrative. And so if you see at the very first red highlight, we say there was reduced A1C in this intervention group after the intervention and after follow-up. And our themes showed us that participants believed that they had control. So if you remember, I talked about you could get confirmation, expansion, and discordance. And this to us was confirmation that there was reduced A1C, not just based on the objective measure, but also based subjectively from what participants told us. Now, in the middle, you then see expansion, because when we did our statistics, there was no significant changes in our psychosocial factors. However, even though there was divergence, we got more insight and we got more expansion because our participants told us that there was enhanced social support from the pharmacist. So we are getting more insight than we would have got if we had just done the quantitative, because it would have told us that there was just no significant changes. And then finally at the bottom, you see, though the quantitative data showed no significant differences, in this case, I almost think like it's maybe discordance, because our quantitative data told us that there was no significant differences in medication adherence over time. However, when we looked at what participants told us, they told us that they believed that their adherence improved. So we begin to see a little bit of difference between what the quantitative data tells us and what participants are actually telling us happened. So I just wanted to quickly run through an example of another design, because I've spent a lot of time talking about explanatory sequential. I wanted to show you an exploratory sequential mixed methods design that we also did to also communicate, putting qualitative and quantitative together. So to give you a little bit of a background, we know that poor adherence, medication adherence happens among African Americans and Blacks. We see a lot of interventions that have been done. However, a lot of them don't account for the unique perceptions that African Americans have. And so we wanted to adapt the current instrument that is actually measuring illness perceptions, because the one that we see right now is only validated in a Western European group. And so we knew that we needed to culturally adapt a new instrument that, and we needed to uniquely assess illness perceptions of African Americans. So we use an exploratory sequential because basically we are in development. We don't know much about the beliefs that African Americans have about type 2 diabetes. We do not like the instrument because we've also seen studies tell us that it has reliability and validity instruments. So we don't want to use the same one. And we also want to check for the reliability of this tool. Now, we communicated using a procedural diagram. Now, the procedural diagram I showed you was very horizontal. This one was sort of more vertical. And we communicated this, and we actually put this in the grant proposal using, included this and communicated how we were going to do our mixed meta study design. We had 3 phases. We had the qualitative, where we were doing our focus groups, doing all our in vivo coding. Then we showed our integration in our phase 2, where we communicated to the reviewers that our qualitative findings were then going to inform the survey, and we were going to write new surveys, we were going to adapt surveys. Then our final phase is then the surveys, the psychometric testing, Cronbach's alpha, and all of that. And then we communicated again how we were going to bring our qualitative data and quantitative together using joint display, which is the blue column, and we were going to be looking for congruence as well. So quickly, briefly, I'll just show you, because remember, I talked about both types of data have to be rigorous. So we spent a lot of time doing these focus groups, 6 semi-structured focus groups. We did content analysis as our approach, both using deductive and inductive approach. We established the rigor of our qualitative data using patterns checklists. We did investigator triangulation, we did member checking to ensure that our qualitative data approach was also rigorous on its own. These were some of the themes we found. And basically what this just shows you and what this showed to us is that what we found in the qualitative data was actually not represented in the quantitative tool that we were trying to adapt. Some of the things they told us, the consequence of diabetes, the emotional representation, the fear about dying, the fear about the future, getting external control from using peer support. These scales were already available in the current instrument, but none of these unique perceptions were not reflected, which is the beauty of mixed methods. Because if we had not done the qualitative component, and we had used the same tool, we would have ran into validity and reliability problems. Now, beyond the current scales in this current instrument, we also find new domains that we identified based on the qualitative data. And this was where we were able to expand even why African Americans believe what they know about type 2 diabetes. And so by using the qualitative data first, we were able to also capture new domains that we would not have experienced or that we would not have known. So we used the building approach, which is we went from qualitative findings to then build our scales using our quotes to then build our specific survey items. So this is an example. Our theme in this way was called the role of the community. And this is an example of a quote. Somebody said, people in the community, they want to be closed-minded. They don't want to know that diabetes is here. And so using that, we developed our item, diabetes is a silent disease not discussed within the Black community. And so that is sort of the building. And so we wrote a bunch of survey items. We tested for face and content validity as a way of bringing all the data to ensure the validity of our instrument. We also did some cognitive interviews. We used verbal probing approach and think aloud approach, and also started doing some thematic analysis to see if there were differences between our own interpretation and what the participants told us. And cognitive interviews is great because it's a pre-test of your instrument and also a way for increasing the content validity of the instrument. Then we did a quantitative survey. We wanted to do retest reliability. So that was why we had both an initial survey and then a follow-up survey 6 to 8 weeks later. Okay, now this is where I'm coming to, which is how did we bring and communicate all our data in our joint display? We use this, what I call a side-by-side joint display. When we wrote these results, we showed the prior domains of the survey items of the IPQR on the left column. The original survey instrument or the original survey domains is where you have my diabetes does not worry me, having this diabetes makes me feel anxious. Then we also showed in our joint display what we found from our qualitative focus group, the corresponding adapted items based on the qualitative theme and quantitative, qualitative theme and qualitative quote. And then we then looked at the congruence between our qualitative and quantitative to see how many people agreed with that. And that was when we used correlations. And then we were looking for item total correlations, which is just the psychometrics of the instrument. So this is the way we showed how we went from our original to our qualitative data we collected to our adapted instrument and then communicating our correlations. Now, this is just basically showing you, you all know this, sort of the reliability and validity of the instrument. And the reason I'm just showing this is just to show that we also ensured sort of the rigorousness of the quantitative part as well, not just the qualitative part of the data collection or analysis. Some of our reliability results quickly, Cronbach's alpha was good by 0.7 to 0.93. Our test retest, we had moderate reliability, but also we had a really small sample size. I think we only had 29 people because COVID happened when we were collecting data. So we had really small follow-up. So this is very exploratory at this point. We had great internal consistency of our domains, like I said. If you look at the old domains and the new domains, because we went from a 7-factor structure to a 9-factor structure, you see that our Cronbach's alpha were almost similar or either higher in some domains or just a little bit lower in some domains, except for our illness interpretation construct. Now, one of the things that was important in establishing our construct validity is to see if our explanation of the factors that we extracted was actually related to the qualitative, and it was. So when we looked at the different items, we saw that there were consequences on relationships and working family, the consequences on personal life. All the items that we found within each factor were actually related to our qualitative themes that we found in our focus groups, which was really interesting that we saw that as well. And so I just wanted to be able to show that when we looked at the congruence between both, we did see good congruence between both types of data. Quickly, convergent results, there was good convergent validity. We used the necessity and concern beliefs domains because it should moderately correlate with our illness perception questionnaire based on theory. And so it wasn't too great, it wasn't much greater than 0.7. We looked at predictive validity, seeing if it would predict medication adherence as well. And this is just some of the results from that convergent validity that I talked about. Now, I'm going to be honest, because it's very exploratory, the convergence between some of the domains were not as great. So for example, if you see our control domain, personal control and illness coherence and illness interpretation, we had really low correlation between those concepts. But you could see that it was the same for the old domains and also the new factors as well. So it was like, okay, something is going on with that concept. So in summary, what did we find? We found a new factor structure. We identified more factors than we wouldn't have. We conceptualized a domain a little bit differently. In this study, we saw good convergent validity, and most of our scales all had good internal consistency based on the Cronbach's alpha. So what are the mixed methods implications, bringing this back to mixed methods? Because we used this exploratory sequential design, we believed we were able to get more robust development, better content validity of our instrument because of the rigorousness of our qualitative methods. We were able to not just look at the data integration, but there was also convergence between our qualitative themes and the adapted instruments that we also found, and that we also came up with. And that is the end of my presentation. Thank you so much for inviting me, and I will be happy to take any questions.
Fantastic, thank you. I'm going to start off with the questions, and then we'll open it up to everyone else. One question that came up as you were giving your presentation about the timing of qualitative versus the quantitative. When you're doing something that is more explanatory, how do you minimize the risk of a confirmation bias creeping in, both when you're interviewing your subjects, either in focus groups or in interviews, and also when you're doing the analysis? So what methods do you use to minimize confirmation bias?
So can you tell me a little bit, Dan, about what you mean by confirmation bias?
So one of the examples that you gave was regarding medication adherence, and that those who were more adherent were more likely to use some type of aid in their adherence, and be able to be adherent, and those who did not time their medications around meals or something like that. And I could absolutely see a situation when you're in a focus group or even individual interviews where the interviewing path may diverge for someone who is adherent versus not adherent. So, and you may end up getting different types of information that may confirm some of your biases. You may not ask the same questions of people who were adherent about their food because they're talking more about their adherence aids. So how do you minimize that when you're interviewing people, and how do you minimize it when you're analyzing as well?
Yeah, thank you for that. Thank you for that explanation. So something that we've done is everyone gets asked the same question. Now, you as the researcher, you know that the individuals within this group are the ones that you saw increase the adherence, and the individuals within this group, you know that their adherence decreased. When you approach the interview, you are not going in saying, oh, your score was low, or you are this group that has decreased adherence. You are asking the same questions to these individuals about, oh, what are some of the barriers that you see? What are some of the issues that affect your medication adherence? So even though you as the researcher know that the interview guide is the same, and one approach to do that is to make sure that the same people who analyze the data is probably not the same person who is also conducting the interview as well. So that might also address this bias that you're seeing, is that because sometimes if you are the same person who analyzed the data, you know going into the interview that, oh, these are the people that did bad. But if somebody else does the interview, they have no idea. All they have is the guide, all they have is the script, and they are asking the same questions. So that is one way of minimizing the bias that at the point of data collection. Now, at the point of analysis, the data are separately. You have to remember that you're going to be analyzing them separately. You don't bring them together at the point of analyzing them independently. The time you bring them together is at the mixed methods level analysis. So when you do your quantitative, you found your results, you have them separately in one section. Then you conduct your qualitative, which that data has been collected by an independent person. It is at the second or third level of analysis that you actually bring them together in your joint display or in any other way that you are trying to report your data. Does that answer your question?
It does, yes, thank you. What other questions do we have? Anyone here or online? All right, we are approaching the end of time. I don't hear any more questions at the moment, but if you do have questions, feel free to send them to me and I could forward them to Dr. Shiyanbola. I want to thank you so much for a wonderful presentation. It was really eye-opening, helped me understand a lot, me in particular, and probably everyone else too, understand a lot more about how mixed methods or qualitative work can be integrated more completely or better into some of the work that many of us are doing. So thank you so much.
Thank you. Thank you. And hopefully I get to see everybody face to face in July.
Yes, we're planning on that. Hopefully we'll have a chance to sit down and talk some more.
Yeah.
Awesome.